Question for Beatrice. So obviously the recurring theme we see with CMV reactivation is probably steroid use. So I wondered if you'd actually looked at your results either corrected for both lymphocyte count and steroid dosing at the time. So obviously they're lympholytic. Obviously a lot of the negative results you probably get are from the fact that they have a very low white cell count at the time.
Either of those variables, which was surprising to me as well. Um, I don't know if this is similarly just holding it performatively. For the transcriptomic study, I'm sorting through the data for the lymphocyte count at the moment as well, but it doesn't look like there's too much, but it's really hard to interpret as, I suspect all the patients that we had were pretty lymphodepleted. I think that's probably why there probably wasn't that much differences between them, and that's probably what the main limitation is.
Amanda, I have a question for you. Were all the sites that are enrolled in the study able to get ganciclovir levels done locally, or did their laboratories have to set up additional infrastructure to facilitate that?
No. So even in Melbourne, we send our samples to Queensland. So no, definitely not. And that has been a major limitation to us setting up in other countries as well, in them getting their assay set up. But we allow for people to send away in a couple of days for the results to come back.
Thank you. Scott, you have a question?
Yeah, thank you. My question also is to Amanda. I was interested in your talk. I'm currently co-supervising a pharmacist PhD where we're doing some similar therapeutic drug monitoring, trying to correlate what we can measure with both efficacy and side effects, but with immunosuppressants rather than with ganciclovir. One of the things working with pharmacists that you find is that they love AUCs. It's the standard measure of exposure. From what you said, you had a lot of other measures of things. You had peak concentrations, trough concentrations. I've always wondered if I was a virion, rather than being worried about being gradually ground down by being exposed to this stuff, that I'd be more anxious about whether it reached a toxic concentration for at least some time and maybe for a minimum time. Have you looked at whether there are any of the other markers that you've measured, such as particularly peak, but other things like trough concentration as well, to see whether they correlate any better with either efficacy or toxicity, given that the preliminary data you presented seemed to suggest that AUC didn't actually predict all those things all that well?
Yeah, no, we haven't done that, and we definitely, when we get more data, we'll explore that more. But I think you're exactly right. Like if you look at aminoglycosides and efficacy, there's some good data around efficacy related to AUC, but then toxicity is definitely related to trough, like because of drug accumulation. So I think there definitely would be some correlation either with drug accumulation or peak concentration. We should definitely look at that more.
Marianne, I have a question for you. Some of the data you presented showed really impressive turnaround times for the testing that was available, obviously performing much better if you had a positive culture to work with. What do you think are the main barriers for us at the moment, aside from cost, which I know is not insignificant, to actually seeing that in real world scenario in clinical use?
You mean from the positive blood culture?
Yeah.
So I think, as I said, streamlining the process and also having thresholds. So because when we see these studies, each group consider different values, different thresholds to identify a pathogen. So to define what a detection truly means, it's another important thing. Is this a true pathogen? Is this a contaminant? So there are a few important things that still need to be decided, like a protocol, a standard protocol for everyone to use, not a different one for each group.
Thank you. Beatrice, you have a question? Shall we get you a microphone? Here we go.
Just had a follow-up question to that. Do you know if cell-free DNA is available at all in Australia?
Um,
Or I guess in a research capacity? Well, I suppose not.
well, there are currently two commercially available tests. So one is the Carriers test that's done in the USA, and the other one is the Discover test that's done in Germany. We are going to run a trial with the Discover, but I think that out of research, it's not available here in Australia as far as I know.
Thanks.
Beatrice, don't let go of that microphone just yet. So I have a question for you. So thank you for explaining the quantiferon test principle, which I think you did beautifully. And then you mentioned that there was that inverse relationship between mitogen response and risk. What do you think is the applicability in these patients? And are there actually any assays where you can just measure a mitogen response, or do you have to burn the cash to use a quantiferon or a TB gold?
I think this is like one of my soapbox topics. I think the finding of the mitogen is interesting because potentially that reflects like a broader assessment of immunity for these patients, and certainly there are lots of more uh, exploratory novel tests, talk virus, things like that, to try to work out some sort of measure of overall net immune suppression of across the course of transplantation or in immunocompromised patients. And I guess the fact that the mitogen in this particular test is very similar, the same as the quantiferon gold mitogen, I wonder if that could potentially be a cheaper and more universal test that we can do at our center. I think we would do it for anyone who has epi risk. Correct me if I'm wrong, Sam. And certainly, I think down in Adelaide, they're now doing it universally. So we're actually looking at a multi-site retrospective study to see if that mitogen response, that number, correlates with any sort of post-transplant infectious outcomes. And we're going to start off with the renal transplant cohort.
That's great because, yeah, the CMV quantiferon test, even though Rajiv Khanna was instrumental in its development, is not actually available locally. We have to send interstate, and because of the special tubes that are required, it's very slow process because you have to get the tubes first and then send the tubes back. Yeah. Okay. Now, if we don't have any more questions from the audience, we might actually move on to the final segment of today. Before we do, though, I'd just like to thank our speakers from the session one more time. I thought that was fantastic. And thank you all for being here.